Of course I will. What I want to talk about is something that is near and dear to my heart, and this is something that I think you're going to see a lot of and a lot of press on very, very soon. Something we've done actually for almost 20, now about 18 years, but something that's really starting to come into vogue now, and this is extracorporeal CO2 removal. And it's basically what we're doing is I am trying to, in a personal vendetta, take the ventilator off the market. And that's really what I want to do. I want to take a ventilator and make it, because really you think about it, what do we do with a ventilator? We put a tube in that bypasses every normal defense mechanism we have. We pump air into a lung that is supposed to suck in air, not be pushed in air. And the alveoli respond very badly. And even if you look at normal lungs that get a ventilator, even for a 24 hours, overdose or post-op, they all get lung injury, 100%. You put a ventilator on anyone, it is an injurious process. So what I'm trying to do is make everyone not ever, ever need a ventilator. It won't happen, but I'm trying. Just use the one on the right? Okay. This has been the face of ECMO forever, right? We put in a cannula, we sedate the hell out of them. They'll never wake up. If they do, it'll be 10 years from now. And this is the way we always did ECMO. And this was a salvage procedure, right? You've done everything else. They're dying. All right, well, let's put them on ECMO. Wrong decision points, bad decision points. And what we're trying to do is make this so that we don't have to do this, because this was the old way to do ECMO, right? You had to cut down, do some kind of vascular graft to the artery, some kind of vascular graft to the vein, and you lost a liter of blood just doing the procedure, and it looked ugly. This is what we do now. They're on ECMO, they're awake, they're walking. Oops, sorry. They're up and walking. If you haven't done this with ECMO, we extubate them. We get them up, we walk them. We take them off the ventilator. We get them up, even though this person required a tracheotomy, they're still at day 3 or 4 up walking. Here's a lady that was actually influenza. At day 10, we had her up and walking. It ain't easy, it takes a lot, but again, she didn't need a ventilator. She needed oxygen support or CO2 removal, but she did not need a ventilator. Here's a young lady that, see the thumbs up? We extubated her. About 20 minutes later, she was 25 days on ECMO without a ventilator. And the reason we did it was because the ventilator is so harmful. And we've known that forever. We just don't know what to do about it. And so we've looked at these therapeutic approaches to acute respiratory failure, and we've kind of dissected them into acute hypoxic respiratory failure and hypercapnic respiratory failure. So what I want to talk today about is mostly about hypercapnic respiratory failure, because that's really where we're seeing ECMO going, is not so much this hypoxic respiratory failure anymore, but this hyperoxic, the COPD or the asthma, things we never really thought about before. So why are we talking about this? Because it really, if you think about it or look at it, hypercapnia, we used to think was, well, so what? The CO2 is high. As long as the pH is kind of normal, who cares? Well, it actually turns out it makes a huge difference. And their studies suggest that hyperoxia had a reduction in pulmonary inflammation, mainly because you turned down a ventilator. Turns out that ain't true. And look at this. There's a pH-independent CO2 signaling pathway. Irritating, right? completely irritating. Why would God do this? Well, one is because we're supposed to have a normal CO2. And what happens is, if you look at CO2, it inhibits cell membrane repair, alveolar clearance of fluid, it becomes very impaired, and there is suppression of innate immunity. So if you have respiratory failure and a little bit of a bacterial load, now what happens? If you become hypercapnic, then you actually start inhibiting the innate immune system from clearing those bacteria. And it's pH independent. So it doesn't matter if you're acidotic or alkalotic. And again, the things that we thought were okay, which was, all right, let's just let them be a little hypercapnic. Let them have a CO2 of 80. Let them have a CO2 of 70. As long as their pH was normal, it's okay. Well, it turns out it's not okay. And there's impaired Na and our sodium and potassium signaling pathways that are also pH independent. And so what else happens? Well, we know there's enhanced vasoconstriction, there's increased arterial pressure, and all of these other issues. The main one, the one that I want to really stress, is there's decoupling of the RV. And if you want to know anything about ICU medicine, the patient goes where the RV goes, or the RV goes where the patient goes. If your RV is sick, it doesn't matter what else you do. If the RV is bad, you will not get better. And so what happens in hypercapnia is that the RV starts dysfunctioning, and it dysfunctions in a very big way. And here is another, just, you have to have a slide, right? And you have to have a graph. I can't give a talk without a graph, right? So you have to have one. And it shows here that there's significant inflammatory differences between hypercapnia and normocapnia. And it doesn't matter if it's hypoxic or ARDS or COPD. If you're hypercapnic, you will get significant inflammatory changes. And it's probably because that you're not getting good clearance of the bacteria. Again, same thing. Well, why didn't we know this? Well, we actually knew it in 1959. We just, no one told anybody. But it also told us this, is if you look at it, we don't need to breathe to oxygenate, right? And we're always told you have to have a respiration. You have a respiration to get rid of CO2, but you do not need respiration to get oxygen. And this is the first paper that showed it, but no one, again, read it, obviously, or talked about it. Because what do we have to do? You got to breathe. What do we know about all that? What is the latest stuff in the resuscitation world? If you give someone that is coded, and what do? We intubate them, put them on oxygen. What's the outcome data? The ones that get oxygen have the worst data, have the worst outcomes. Why is that? Because you don't need oxygen. You need to get rid of CO2. Ain't that interesting? So I thought it was. So what we started looking at, like I said, 20 years ago, was actually, can we get rid of CO2 in a very benign way? And we looked at it and said, if we had the right membrane, oops, whoa, my gosh, what the heck? All right. Any questions? Uh-oh. Anyway, so there was a man in a bar. No. Okay. All right. So, as I was saying, okay, thank you. All right, so I'm not getting the award next year. Okay. maybe. And I'm pointing at the screen, and it's over here, right? All right. So as I was saying, so we start looking at it, and comes out that, you all know this because you're perfusionists, but CO2 has much higher diffusion coefficient. So you can get rid of CO2 very, very easily. And if you look at the dissociation curves, and you can see here, oxygen dissociation curve sits here, but you can get rid of CO2. All you have to do is just show it something. Show it a little air, and it will get rid of it. And we use this to our advantage. And if you look at Gatnoni and Colombaugh, who is just one of the most brilliant researchers in lung disease, he showed very early that it doesn't take almost anything to get rid of CO2. I can run 500 cc's a minute and get rid of almost all the CO2. So it doesn't take a lot. And so in Milan, they did a study and they said, hey, you know what? I can hook up this guy, put in a couple of cannulas, put them on a ventilator, but I can get rid of almost all their CO2 with very little effort. And so they did a study. Well, actually, anyone here from Utah? Thank God. Because Alan Morris did this study, and he said, well, ECMO doesn't work. And that was published. One, he's an idiot. Two, he's obnoxious if you've ever met him. Right, Bill? Yeah, he's right. The second thing is he never did ECMO. He did ECO2R. And the first patient he ever put on ECO2R, ECMO, or anything was in this study. We all know there's a learning curve. And so what he said is ECMO doesn't work. And it actually, in fact, that's not what he said. He said ECO2R didn't work, but the reason is he never put them on really good ventilation. They had, look at that, plateau pressures of 50. They were cannulated by cut down, so they bled. And they said they had almost 1.7 liters a day. What? What do you do in Utah, right? I mean, is the altitude or what? But you don't do that, right? I mean, that's unacceptable. But he got so much mileage out of this that he became one of the biggest inhibitors of how and why ECMO did not really progress. And it's because he did it badly. They did it very badly, surgically, and he misinterpreted the data. So anyway, and this is why this happened, is just, we just lost it. So where from here? Well, I'll give you a couple of studies, and this is a 13-year-old that presented to our institution with asthma. Peak pressures of 50 on 2 milliliters. That ain't a lot of ventilation. You're talking about 80 cc's of ventilation. Rate of 4, it took him 15 seconds to exhale, completely exhale. And so what we had was this. We had this give a breath, 15 seconds. So what is the fastest rate I could give this kid? Rate of 4. If I don't, then I'm going to get air trapping and auto-peep and hyperdynamic inflation. And that's basically what had happened. This kid had been given so much ventilation that he was really on the verge of and I don't know how this kid did not get a pneumothorax. So what was our options? Well, one is just ECMO, or just let him have high CO2, which we know is not acceptable, or just hope. Give him a little ventilator, give him some steroids, and hope he does it. Well, we're not smart, so my partner, Steve Conrad, and I decided to do this. And we basically put him on an affinity oxygenator. And we were able to do this, I think. There it is. Within 1 hour, in turning the ventilator off, putting on pressure support. So we basically turned all respiration off, put on pressure support. We got their PCO2 from 188 to 50. And we got his pH up to there, turning the ventilator off. So basically we paralyzed the kid, turned the ventilator off, and we're able to get almost total CO2 removal. Now, what's nice about this, to go back, is this off the shelf. This is not a product you have to buy. This is off the shelf. This is Medtronic Affinity standard tubing. And so the way we designed it on purpose was to make it open source. Just like you do with whatever computer program you have is. We did not want this to be a commercial product. We wanted this to be off the shelf. Just grab it and go. And we can put this in 15 minutes. This was a 12 and a 16 French cannula. Put them in, and we got it in 15 minutes. So pretty quick and pretty nice and pretty sweet. And here, I don't know if you can see here, see the humidity. Humidity, that's heat transfer. What goes with heat transfer? CO2 removal. And it's almost complete. When we did the first studies on this, we actually took 4 patients and paralyzed them. Now, you try to get that through an IRB today. You couldn't, but we were dumb and they were dumb, so they allowed us to do it and so we put 4 patients on. Total CO2 removal was achieved at 500 cc's a minute. You can do that with any blood pressure. So we did this with complete, just allowing their blood pressure to occur. Here's a 10-year-old with asthma. Again, same thing. pH was 708, PCO2 was 88. He was intubated. And again, same thing. We could not ventilate this kid. And with just a couple of minutes of putting on this CO2 removal device, we got the pH to normal, PCO2 to normal, and again, we did it under an hour. Turning the ventilator off, pretty cool. Everyone loved it except everyone. That was like, why aren't they breathing? And we were able to publish this, and we did 4 case series. We've done now 30 or 40, again, showing the same thing. Novolung is now out in Europe. It's actually here in the U.S. and I think in research phase. Again, all you need, you don't need Novolung, you don't need anything, you just need a low resistance oxygenator. But again, same thing. The military picked it up very, very quickly. And they did it actually after the first Gulf War. And this is actually a soldier. This was sent to me from one of my former fellows that is now at the lung rescue unit at not Walter Reed, San Antonio. But again, same thing, Novolung. This is how the military transports ECMO. Wouldn't you love that? You get a C5 in this, but thank God for them, right? This is actually a lung rescue unit. They will fly anywhere in the world, and they can be there in hours with either ECMO or AVCOR, and they do it with a Novolung. And the entire plane and the entire crew is dedicated to that one patient. It's pretty cool. And I actually trained him, so that's even cooler. We now have a new system called the Hemalung. It's through A-Lung, and they're looking at, in Columbia just finished their first series where they took COPD patients, brought them in, did not intubate them, they cannulated them, put them on CO2 removal device, and they actually did well. Their first patient series looks really, really good. We're actually about to start a large series with the Pittsburgh group. We actually now have a CRRT machine that will do CO2 removal. And that will do it with a simple little device, 14 French. I'm going to go back to, to this. This is what it's going to look like. This is what ECMO is going to look like. And this is what CO2 removal is going to look like. And this is what the ventilator is going to look like in the future. No longer is it going to be a tube. It's going to be a cannula. And as perfusionists, I think you guys are going to be at the forefront of really marshaling this in and saying, it's okay. It's okay that they don't breathe. They're in the OR all the time and they don't breathe. Just take it to the ICU and just let that happen for a long time. And like I said, you know, we know now that with ARDS and other issues, permissive hypercapnia and allowing the CO2 to rise is no longer acceptable, and it leads to RV failure. And RV failure, if you want to know anything about ICU medicine, if you're going to live, it's because your RV allowed you to live. And if you're not going to live, it's because your RV failed, or we allowed it to fail. And so, again, CO2 acts as a signaling molecule, pH-independent mechanisms, and it inhibits cellular repair, alveolar fluid clearance, and suppression of immunity. That's huge. That's huge. Again, just shows that with your CO2 removal, your RV improves, and we can see this. We have this Medtronic device, we have the novel lung. All of these are very commercially available. The Medtronic device, very, very cheap relative. We have them actually make a kit, and the kit is just a few $100, and we can put it in the ER or in the ICU within 15 minutes. Again, you know, you just have small ports, but here's what it's going to look like. We have all these devices out there right now. All of these are, most of these are not US. And again, the A-lung and the Hema-lung, we're about to start a large series. So I hope that y'all will want to participate, and please email me if you do, because I'd love to recruit as many centers as we can. And again, these are all the trials that have happened, and it just shows that no matter how you do it, it works. And I just want you to know that this is the future. So the ventilator is actually it's the way of the past. And extracorporeal CO2 removal, extracorporeal oxygenation is the future. Stop putting in ET tubes in these patients and start just doing extracorporeal. So I actually got to the end.